Good afternoon, everyone. Sorry, actually, it's my fourth attempt, so I think this time nothing disturbance will happen. So my case is the bifurcation PCI. Seeing is believing. So this is my patient, a 60 years old gentleman. He admitted with typical chest pain and diagnosed with a case of the unstable angina. And his ECG was initially normal, and echo finding was there is no regional wall motion abnormality with good ejection fraction, and there is a minimal pericardial effusion stain on the echo. So after discharge, patient again came to our hospital for coronary angiogram. On angiogram, we have seen that is the finding of this coronary angiogram. We see there is a critical disease in the proximal to mid LAD at the level of the diagonal. With bifurcation lesion is the Medina 111. The RCA was normal. If we assess the lesion, we see there is a non-bifurcation, non-left main bifurcation Medina 11, and there is a side branch was a large one, and the angulation between the main branch and the side branch was less than 70 degree. So we consulted with the patient attendance, and we decided to go for revascularization. So our strategy was. We gave the patient all the options, but our strategy was they also gave their consent to go for the PCI. So what will be the strategy for this kind of lesion? Is it a direct signal stent strategy or provisional stent strategy or upfront double stent strategy? In that case, as there is a Medina 111, we decided to go for the upfront double stent strategy. And among the upfront double stent strategy, we know there is a many techniques like DK crush, mini crush, culotte or tap. So in that case, we know according to study, according to definition, 3 criteria. In non-left main bifurcation lesion, there is some major criteria and minor criteria. And in case of DK crush, there is a less chance of the TLR or target vessel revascularization or less chance of cardiac death. So we decided to go for the DK crush. We followed all the steps. We wear the LAD and the D1, and we pre-dilated the lesion in the D1. We put a stent and from D1 to the main vessel LAD. And then first crash was done, and then we did rewear to D1, and we did the first case, and after that we put a stent to LAD, the main distal main branch to proximal main branch, and this is the second case, and we recrossed the wire to the diagonal, and we did a first pot, then the second case, and the repot. So that was our terminal result. We are happy. All the team is free flow, and there is no visual residual stenosis seen. So the post PCI follow-up was very good. The patient no ECG change, and patient was kept on DAPT, this ticagrelor and aspirin. We kept the patient 1 day on CCU, and then after that we transferred the patient to the cabin. But on third day, what happened? The patient complaining about the chest pain and the shortness of breath. So initially we decided to go for a ECG to look upon what was the cause. So this is the ECG. We see the gradual ECG. We see there is a slight ST elevation. You can see in first ECG in the 1 AVL in the lead 2 and in lead 5/6 V5/6, and later on the second ECG the ST elevation is progressing. So the elevation, this is not following any temporary, any particular reason. So we decided to go for some investigation. The troponin I, it was initially 1.4, a little bit raised, and on subsequent sample, it was gradually decreasing. And hemoglobin was good, and WBC count was 15,000 almost, and CRP was a little bit elevated. He was also complaining the shortness of breath. That's why we did the pro-BNP. It was 11,000 and 1100 initially. So at that time we did echo again, and we see there is a moderate pericardial effusion, it's 12 millimeter, but there is no regional wall motion abnormality. Initially it was 4 to 5 millimeter, a little bit increase of the pericardial effusion, and importantly there is no feature of the RV collapse. So what may be the cause of this kind of ECG and complaining of the patient? Is this an acute MI? Procedural related acute MI, or any acute pericarditis or myopericarditis, or this is the case of the tamponade or perforation of the coronary artery or aneurysm. So, and in that case, what treatment modification we need? Should we continue the DAPT or we shift to the single antiplatelet? We should start the unfractionated or inexaparin. we should start NSAIDs, corticosteroid, colchicine, or antibiotic. And unluckily at that time, my Professor Azam sir, he was out of the country, so I was a bit dilemma what to do. So we consulted our phone, and we decided to go for DAPT, but dose is lowered. Initially, the ticagrelor was 90 milligram BD. Then we decided to lower the dose to 60 milligram BD, and we started NSAIDs. As this, we suspect this is a case of the acute pericarditis. So we advise ibuprofen and colchicine. So what to do? Should we thrombolize the patient? Should we go for the check angiogram? Or should we go for the pericardiosis or observation or follow-up? And in that case, we decided to go for the observation and regular follow-up. And at follow-up, we see the extension of the pericardial effusion 14 millimeter. His tire function was normal, but hemoglobin is little bit down, is 8.16, so we gave 1 unit of blood, and WBC count is little bit increased, 16,500. But later on, his troponin count became normal. So on 9th day, the shortness of breath was increasing, and the patient kept on inotropic support for his cardiogenic shock. Echo shows the early feature of the RV collapse, and we made a cardiology board, and we decided to go for the urgent pericardiocentesis under fluoroscopy. We drain out the 200 ml of fluid and kept the pigtail in situ. So on next day, the patient condition deteriorated, and repeated suction shows the clotted blood. And we did a bedside echo. We see the pigtail in the RV. So immediately we transfer the patient to the cardiac OT. And before cardiac surgery, we did a rapid angiogram. We see there is a pigtail in the cavity and cardiac chamber. And the repeat angiogram shows there is no alteration of the flow in the LED or D1. So then removal of the pigtail and RV repair was done. And post-surgical period was uneventful, and patient was discharged on 8th post-operative day. We see the ECG came back to normal, and the effusion was decreased. So we have to, if we think on narrow angle, we can see, here we can see that there is a boot over the head of the baby. If we wide our angle, we can see there is this funny picture, the baby is himself doing this scenario. So what we learning point, the serial ECG monitoring is necessary in all post-PCI patient complaining symptoms. Complication may happen even after successful PCI. Don't be panic, consult with your seniors, and prompt decision making saves life. Thank you all. Thanks for patient hearing.